Happy Republic Day. Today we have with us Dr. Raghavendra Kumar. He is a very well-known child and adolescent psychiatrist in Bangalore. He is the founder director of Mana Mandira Healthcare in Bangalore. And today he is going to talk to us about understanding childhood OCD in autistic individuals. And we have received a lot of questions from the parents, so he'll be addressing them as well. Thank you so much, sir, for taking time.
Most welcome. Thank you. Thank you for the opportunity to talk to parents, a huge collection of parents, a group of parents. It's always very educating. It creates awareness in me also. It makes me understand things better when I speak to parents, especially parents who are handling things hands-on. Do you want me to wait for some more time, because I see only 12 people?
I'll send out a few reminders, sir. Yeah, we can wait. Maybe
you
can get
for 2 minutes.
Can share the recording too later on.
Okay. Let me just start sharing my screen then. Give me 1 minute. Can you see my screen?
Yes, sir.
Yeah. Good morning, everyone. I bring greetings and wishing you all a very happy Republic Day. From Mana Mandira, our team. We are a team of 12 people, and we are still growing. We have child psychiatry, adult psychiatry, child psychology, adult psychology, plus art therapy, play therapy, speech therapy, occupation therapy, and we even have Ayurveda psychiatry. So it's like it's a holistic team under one roof. And yeah. Shall I start?
Yes.
Shall I continue?
Yes, please.
Yeah. So see, I'll not be spending much time on the presentation. I don't want it to be one way. So I'll try to make it as interactive as possible. So the first 20 odd minutes, I'll be dedicating for presentation, and then the rest will be interactive and more of discussion. So just and see, the topic was OCD in kids with autism spectrum. But first thing is, I also would want to talk about OCD, and then we can discuss about because one subset of kids with OCD might have autism spectrum and vice versa. So understanding OCD is important first. So what does OCD stand for? Obsessive compulsive disorder. Okay. So sometimes usually it's both present, but sometimes it's only compulsion or sometimes it's only obsession. And there is a lot of time spent on doing these things, and there's significant distress and interference. That is like they keep doing those hand washing, people with OCD, hand washing or checking, those things at the cost of other productive. So the direct and indirect cost, that is because of the man hours lost plus the medical cost, everything. is around $8 billion per year in the US. Indian stats, I'm not very aware. There are not many studies like this. Because US is a insurance-driven country, it's calculating these metrics is a lot more easier. And clinically and etiologically, it's a heterogeneous group, meaning everybody will not have the same set of symptoms. Like if it's malaria, everybody will have chills and rigors. Everybody will have fever. But this is a heterogeneous set. Like somebody will have washing, somebody will have only thoughts, somebody will have only checking, somebody will have only sexual obsession. So it can vary. And there is a subgroup where there is an early onset subgroup. And around 50 to 80% begin before 18 months, 18 years of life. So as we see, usually what we see in adults, actually, if you trace it back, there are roots in their early adolescence or sometimes in childhood itself. Around 60% remain with symptoms despite medication is what this line says. And some historical, so it has been reported and recorded for several years, several centuries ago itself. And various people have given their own accounts, but now they are not very relevant. The lifetime prevalence is around 1 to 3%.
OCD?
Yes.
And that is if you take in their lifetime, not cross-sectionally. Like, so a person in his lifetime, and if you take 100 people and follow them up for their lifetime, around 3 people, if you take 100, then 3 people might have, 1 to 3 people will have this illness. And like I said, no, around 33 to 50%. So sorry, around one third to one half, that is 33% to 50% will have symptoms before puberty. And the point prevalence in children and adolescents is 0.7% in one US study and 0.25%. So at any given cross section, if you see what is the prevalence of OCD in children and adolescents, it's around 1,000 out of 7. So, and depends on several other factors also. The incidence has 2 peaks. So one is 7 to 12 years of age, and age 21 and above. So that is early adolescence, early middle childhood and early adolescence. Boys are more commonly affected, and around age 21, usually in like the second, third decade of their life, women can be more easily affected. And so basically obsessions and compulsions. And like I said, I have seen people who have missed their flights, who have spent 8 hours washing so much so that they have missed their flights, they have missed several important commitments, and so it can be that distressing. And subjective distress, obviously. So the reason that it says subjective is because obviously the family will be distressed with somebody occupying the bathroom for so long. That is objective, but subjectively, they might feel it's fine. They are doing it. So some people. So sometimes it's subjective, and it interferes with life. Obviously, not just the life of the person affected, the people living around that person. So you need to remember these characteristics: intrusive, unwanted, unpleasant, uncomfortable, distressing, and anxiety provoking. So it has to have these qualifiers. Any I'm sorry, I'm down with a cough and a cold. I'm recovering. I'm sorry. Please forgive me if I cough in between. Yeah. Intrusive. So intrusive, say you're doing something, some activity. Suddenly, like say you're reading for exams or driving a car, about to go somewhere. Then suddenly you get a thought, did I lock the home properly? Did I turn off the gas properly? So it's intrusive, so much so that you forget the task on hand and you have to come back. Maybe if you come back once, okay, understandable. But if you come back so many times, or if you don't even get into your car because of these thoughts and you keep on checking repeatedly, then definitely that's intrusive, unwanted. Obviously, it's unwanted because they know that they have turned it off, and it's unpleasant and uncomfortable and distressing, and obviously distressing and anxiety provoking because they get very tense. What happens? Like, say, if they don't turn off the gas, the entire house will blow up, and then I will be responsible for that. So, and this need not just be thoughts. That is, it need not just be ideas. It can be an image, intrusive image. Uh, I know of a client who has thoughts of uh, uh, gods coming and other things coming, and then getting lost in that, and fears, worries. So there are several things. Basically, it can be in they can hear voices, they can see images, and they can have those thoughts. And for them, it's as real. So that is obsession. So obviously, when somebody has that much amount of a compelling thought, what will they do? They will involve in, so to avoid the distress. That is the core thing you need to remember. To avoid the distress, they will do compulsions. So, and this is just a reminder that this is a classic clinical feature in people who are neurotypical. Neuroatypical, that it will be different because they are neuroatypical. The symptoms also will be a bit neuroatypical. Okay, just a minute. Huh. So compulsions are repetitive behaviors or mental acts. So you can, like, say, you get a bad thought, then in mind you pray, you have to pray this many times. So it's a mental act, and many times it's not seen. Mental compulsions. And repetitive behaviors like washing, cleaning, checking. And one kid I remember, that kid had bad thoughts about God. So he had to pray this many number of times repeatedly, failing which he would get very distressed, and he used to spend so many hours. And compulsions without obsessions more likely in younger children. I'll come to that. So, and it has to be like this. So that, like, say, 20 times I have to pray, or I have to pray in this manner, and then it becomes, so the slightest doubt they get, then they will start doing it all over again, and that will not give them satisfaction. And compulsions without obsessions. See, obsessions is basically a thought. If a child is not grown up enough to appreciate their own thoughts and appreciate their own thoughts that these are unwanted, so they may not report that. So rituals of touching, sorry, touching. We'll come to that later on. Sensory phenomena and tics and all those things. We'll come to that later. So, see, the age at onset, there is no clear consensus, but usually what is more important is what there are two metrics. When did the age start, and when did it start interfering with functionality? Like, I'm seeing one boy now who is around 8-9 years old, and the interference in functioning is very little, very mild. They came to me for something else, and I incidentally discovered this on probing. I discovered this boy has OCD, and so it has, and the parents took a lot of time to understand that, okay, this is an illness and this is interfering in his function. They thought it was just a part of a reluctance or a laziness of a child. So like that. So, but the thing is, early onset usually around 10 or before. Late onset is, so that, like you see, around 60 to 80% the onset is before 18 years. So, but still it is not early onset, it's late onset. Early onset is around before 10 years, 10 or before 10 years. Meaning, so the symptoms, so one major subset of kids, people with OCD, it starts early in their childhood. I have seen 36, 37-year-old adults who have had OCD for almost 30 years of their life. Yeah. So, and obviously, so if left like that, then obviously if it goes into, so it starts early in adolescence or childhood many times. And so in adults, when it becomes, it's definitely it's greater severity and significant persistence of symptoms, and very less, as many times it's less responsive to treatment. And early onset, especially in like younger child, 6 years, 7 years, they have very few obsessions. It's more of a thought, and they have more of tic-like compulsions. So the compulsions which they do automatically, and obviously there are more comorbid tic disorders in this. And early onset may have high symptom severity. There are aggressive obsessions and compulsions. Sexual and religious obsessions and compulsions are also common in childhood. And symmetry, ordering, and arranging obsessions are common. This is where autism spectrum also kind of can become very confusing, because kids with autism spectrum disorder have they have their need for symmetry, need for ordering, need for arranging, and so that is where the confusion also arises many times. And the commonest subgroups like the based on the symptoms uh, are ideally contamination and cleaning domain, obsessions, basically like any doubts and then checking, and symmetry and ordering and hoarding. So these are the four common broad categories uh, under which most of those can be subgrouped symptom wise. And maybe there is one miscellaneous category also which can be added at times. And many of these people with OCD, they have uh, other conditions also, like body dysmorphic disorder. That is about one part of their body, be it their nose, be it their any other body part, the skin, have it's not according to their expectation, and then start checking repeatedly. And many of these people undergo several consultations with cosmetologists, plastic surgeons, and then they undergo surgeries repeatedly. In fact, many times before a cosmetic surgeon or a plastic surgeon does a surgery for people with does a surgery on anyone, they usually take a opinion with psychiatrist also. Usually, not a rule, but many times they take any plastic surgeon who is mindful of these things usually takes an opinion, because then somebody undergoes a surgery and then again it doesn't satisfy the patient. So then they will want to undergo again, and maybe like several times. And tic disorder, we know tic disorder, repeated intrusive the acts, uncontrolled acts, and uh, sounds, production of sounds. Trichotillomania, we know, compulsive hair pulling. And so basically OCD has several other spectrum. This is the DSM-5 classification, the latest one. Previously OCD was an anxiety spectrum, but now they have moved it into separate obsessive compulsive spectrum disorder. So all this, like, what is the common denominator between all these things? The common denominator in all these things is yeah, the commonest denominator in all these things, commonest denominator is intrusive thought, obviously, and it's anxiety provoking, and there are repetitive behaviors, and there is a shared genetic and pathophysiologic mechanism involved in all. So basically, they are like hum panchi ek dal ke. So most of these illnesses arise from the same stem. And around 60 to 80% of people with OCD have one or more comorbidities. And usually, the younger they are, there is usually underlying more comorbidities also. And tic disorder, ADHD, other anxiety disorders like separation anxiety or GAD, generalized anxiety, panic, and mood disorders, that is depression, bipolarity, and eating issues. Hello? Yeah. Any doubts, we can always, if you feel it's important, you can stop me and ask in between itself, or you can type it in the chat box, and then we can discuss at the end. I'm almost finished approaching the end of the presentation. So the commonest comorbidities, around 20 to 60% of children with OCD have tics. 9% are adolescents with OCD have tics, and 6% adults with OCD have tics. So there is a tick-related OCD subgroup, and usually it's a male preponderance, and around it's autosomal dominant, as noted. And there is a major transmission, like say, and many times it's transmitted to boys from parents. And there is usually a early treatment, earlier age at onset, and the treatment is also a bit different. Treatment and the response is also a bit different. We have to be watchful of these other comorbidities. So the course and outcome, heterogeneous. See, there is no single course and outcome in OCD. So that is what they mean when they say it's heterogeneous. If you take 100 people with OCD, not everyone will respond to the same medication in the same manner, and not everybody will improve fully. So, and if you see here, the average people take around 2.5, it takes around 2.5 years, that is 2.5 years, for the diagnosis to be recorded, or somebody to come and seek help, or somebody to take the child to seek help, because there are several things involved. One is, it's not like a fracture, it's not like a fever which is obvious. You can even if a simple X-ray is done for a fracture, you will know any bone which is fractured, you will get to know. But here the disease is in the thought. The thought process has become diseased. So many kids, they keep it secret. They think, I am doing this. They think it's me who is doing this and I'm not good. So there is associated secrecy, shame, and guilt. And many times, you know, right? There are some kids who have certain routines and don't want to change that. So it resembles normal childhood routines. And sometimes the symptoms change over time also. Like when we say, for first 6 months, when it started, it was associated with symmetry, arranging things properly. But later on, it shifted to washing, so like that. So things sometimes the course, the axis and veins, it fluctuates, and the symptoms profile also changes. But there is a thematic consistency, meaning it's about certain theme, like the need for orderliness, the need for symmetry, the need for sameness, and the illness, if left to itself, is usually relapsing and remitting. So there, it might show improvements. That is where many parents feel it was there previously, but now it's better and it has gone by itself. So sometimes, without understanding the illness, people tend to wish it away. Oh, it will be okay by itself. Will they do that to a fracture or a fever? Even a 4 5 days fever, we will go to a doctor, isn't it? But this one kind of people tend to wish it away. And the best thing, I will totally agree with this, and I'll press on this twice or thrice. It's always good to treat it as soon as possible. Like this one 80-year-old child I spoke about, we have picked it so early that the therapy has started, and I'm sure the things will improve in the next 6 months. Things will change a lot, and there is no medication needed for this kid because we have picked it very early. Only mild form of illness. Okay, so there are. Yeah, I'm sorry if the screen is not properly visible. There's a screenshot, and see, simple screening questions are important. So, has your child ever shown concerns about catching a disease after touching something, or unduly worrying about dirt leading to repetitive hand washing? A preoccupation with ordering and or arranging things, so much so that it interferes with normal life or schooling. A need for things to look, feel, or sound just right. So basically, like if things are on the table, if things are not arranged like this, then the kid will, or the bag, the 80-year-old kid I spoke about, in the bag he has to arrange the books in the same manner. And on asking, I just don't feel it's right if I don't arrange it like this. So just right phenomena. And excessive worries, fears, or concerns with aggressive sexual or religious thoughts. One might ask, how can a 7-year-old, 8-year-old might have sexual thoughts? It does happen. They need not be subjected to any sexual, they need not have any sexual awareness, but that still they still have this sexual images. And excessive need to collect or hold objects. They will collect objects beyond relevance. So screening questions plus parent interview. Um, there are several rating scales, but I would always uh, prefer having an interview with the parents and the child and input from teacher and with the child as much as possible, and then have like a session of play and activity with the child and observe the child. So make the child do certain things and then observe. And rule out normal ritualistic behavior of childhood, and assess role of the family. So how is the family reacting? There was a child which I saw. The child used to be so much fixated on drawing margins on the notebook, in the notebook. Initially, the parents thought, oh, he's such a perfectionist, he doesn't want a single change, he'll erase everything. Even a single mistake, the child would erase the entire page and write. And gradually started off, gradually it became tearing off the page. And then they started shouting at the child, and then they started, they wouldn't understand that. Then after several months, maybe even couple of years, then they came with the child. So the role of family becomes very important, and awareness of parents becomes very important. There are several rating scales which may not be of much relevance to parents. So one small deviation. So see, obsessions versus fixated interest. Obsessions in OCD is ego dystonic, intrusive, and ego dystonic means it's distressful to you. I'm finding it very difficult. If I don't do it, I cannot tolerate it. That is ego dystonic. And intrusive. Intrusive, you're doing something productive and suddenly comes, and you don't want that. Very obvious. And in kids with fixated, that is kids who have stereotypies, kids with ADHD, kids with ASD who have stereotypies, they enjoy the content of repetitive thoughts. And in obsession, the efforts are to ignore, suppress, and neutralize. So you want those thoughts to stop, and that's why you do these activities. But then the nature of the thought is so much so that it multiplies malignantly, and then that is where you start doing compulsions. But here in autism spectrum, the repeated focus on thoughts, it's only on thoughts. There is no effort to neutralize it, and the repetitive thoughts can cause distress in obsession. If you stop those thoughts, like say a child is involving in this stereotypy or certain arranging of some things, and then if you stop, then then the kid will have distress. And this typically more persistent intrusive thoughts are frequently in the forefront, and symptoms may only be triggered upon observing a behavior. So again, so if you stop the child from arranging the toys in a particular manner, then the child will get restless. If you stop the child from, if you change the route of the up, like say taking the child to school, if you change the route for different reason, or if you change the dress, if you change the shoes or something, so then these kind of can. So this is fixated interest. This is more of a thought, and there is associated fear about the actions implication. So it's like say you have negative some bad thoughts about God or sexual thoughts. So obviously there is a fear that I'm thinking bad and then some God will curse me or something. But here there is nothing like that in autism spectrum. And compulsions versus repetitive behaviors. uh, Compulsions in OCD performed in response to an anxiety provoking obsession, right? Compulsions where there is an anxiety provoking thought and you do it in like say, did I turn the gas off? That's an anxiety provoking obsession. and then one keeps on checking the gas knob repeatedly, that is a compulsion. So that's in response to a thought. And in ASD, it's not like that. There is a less robust connection with a specific anxiety thought. There's no specific anxiety provoking thought. And so compulsions serve as a basically they help in reduction of anxiety. And this repetitive behaviors, it's not for anxiety relief exactly. It's also for self stimulation and more of a calming mechanism, um, and they're trying to achieve something using that. Okay. This is where again common forms of self-injurious behavior in autism spectrum: hand biting, head banging, self-scratching, hitting, pinching, and hair pulling. OC spectrum and related disorders, hair pulling and skin picking. So the nature is stereotypic. Stereotypic means persistence of an act beyond a point of relevance. Here, it's compulsive. So to really, like say a person gets a distress and tries to pull hair, that is compulsive. And the pattern is fixed, repetitive, apparently purposeless, seemingly driven. And in OCD, there need not be any pattern, and it's purposeful at times. And it's many times it's in isolation. They will try to cover the hair with a hat, and then when nobody is there, they'll try to do it. So we'll leave the genetic part. Basically, there were questions about genetic inheritance also. There definitely a component. OCD is one disorder which has been established that there is a genetic component, but it's not like if the parent has, the child will have. It's not like that. So the heritability estimate is 45 to 65%. The role of family is now very important. Parents, siblings, the significant others. So if a child gets repeated doubts, did I read it properly? Then the child will keep on asking, and the parents will accommodate the child. And the child is washing hands repeatedly. They should try to stop, but they cannot. Or they maybe allow the child to do it, and help. The child wants to order certain things, arrange certain things, collect certain things. They will avoid that. They will allow that. And if a child is avoiding certain, like writing, because of the symmetry, neatness, the child is avoiding, then they will facilitate the avoidance. And this accommodation reinforces symptoms. Like if a child is avoiding, um, writing because it has a lot of symmetry related compulsions, then the child will feel, okay, the parents are also allowing me to avoid, so then it's good. So that reinforces, and this family accommodation has a poor outcome associated with it. And before the treatment starts, it's always important to identify the worst outcome OCD symptoms. Length, meaning in that particular client, you need to know what is the worst OCD symptom, like what is the most toughest and difficult to treat, and the length of illness and how it is impacting the person's life, and what are the difficulties in working with the family, and assess other comorbidities like anxiety, separation anxiety. OCD and separation anxiety are very commonly coexistent. Therapy, cognitive behavior therapy, medication, psychoeducation, and many things. I'll not go into this. Yeah. What does psychoeducation involve? So making the kid and making the person, the affected person, and the significant others in the family aware of the possible clinical symptoms. What are the symptoms and what are the nature? What else can happen? And maybe predicting the course, telling the course, like it will be running like this, and the comorbidity, the treatment options, the duration of illness, duration of treatment, how long it may. So giving them a rough idea about all these things is very important. Failing which they will not understand, and they will run around from one person to another, one doctor to another, and if they're because it obviously the person will be anxious, and his caretakers also will be anxious. So these books I have seen to be helpful. Um, Maybe you can take screenshots of this also. Very simple books, and it helps. But many of these are in a cultural setting. They are more of a US and Western cultural setting. So there will be a cultural gap between these books and the way we can implement and understand. But just to understand the illness, at least these books help a lot. So these are the books. If you see the effect size, that is like the efficacy of the therapy is much better in OCD. OCD is one condition where medications are not indicated if the illness is mild. Therapy is therapy. Please, therapy is the mainstay, I would say. In fact, I will not hesitate to start therapy, but I might hesitate to start medication in many cases. Therapy is very important, and taking the family and the person along with us is very important. Okay, yeah. I would want to convey special thanks to my friends Dr. Puneet Khanna and Dr. Purnima for their contribution to the materials and the literature. Yeah. With this, I would open the. Yeah.
So we have one question already in the chat. There's one from Rohini. She says son is 9, and from the last 2 years he has been having name obsession. That is, he's always talking about his school friends and what they do, how they talk, etc. So any tips to manage this and overcome this?
If I could talk to her face to face, like as in if you could turn a video on and if she can talk to me, because there are certain things. And is it okay if I ask certain questions? Some things I'll not be asking, maybe they are personal, but some things I'll want to know before I answer their doubts, without which I'll not be able to give a kind of a satisfactory answer. So see, talking about friends, how dysfunctional it is, as in what is the difficulty, what is the child doing? Is the child doing only that at the expense of everything else? Somewhere I felt I felt this could not be OCD the way the question was put to me. But nonetheless, see, if the child is talking only about friends, and if you stop, what does the child do? That is the first thing you need to notice. Second thing, if the child is getting distressed and very troubled when you stop, what action does he do? That is one thing. And there can be other things also, like other anxiety, especially in kids. A lot of anxiety symptoms has reassurance seeking, like talking about the same thing again. Like, say I'm worried about my exams tomorrow. I'll ask my mom, Mom, will I pass? Will I pass my exam tomorrow? What will happen? What will I be fine? Will the syllabus? Will there be any out of syllabus questions? So these kind of repeated questions also are present in anxiety. So before coming to a conclusion, it's OCD or obsession, we need to rule other things out as well.
Doctor, actually, it's Shambhu here. Like I'm speaking from my wife Rohini. So that question what we posted. So our son he keeps taking his friend's name to such an extent that he gets engrossed in the same thing, and we cannot pull him back to the other activities, and it leads to a lot of problems like not able to concentrate, focus, such issues.
Problems also.
Okay. How verbal is your child?
Good.
He's completely verbal. He talks and the other thing is he has a good memory power. Whatever the names of the people he collects, right? Like he tries remembers for a long time. And nowadays he has started a few things like he remembers few names from few years back also. Whatever we have met. Okay, some of my friends or some of his friends or my friends or whatever others. So he tries to take their names randomly. So which looks very much irrelevant in any given context or anything. So we know what he is talking about is something not cooked up, but something he has experienced. But taking those names everywhere makes a sort of creates a lot of irrelevant context actually.
And moreover, he's taking one name every week and getting obsessed with them. Like, for example, if he's taking Ethan is his friend and he's telling that Ethan is now eating lunch, Ethan is now having snacks every day. This is every day.
Week on week it changes. The
And he
name
again he
changes.
says Ethan's mom, does she know to drive car? Like he goes to his whole family. He tries to claim them. So again, next week there is another friend's name and the same.
So he gets obsessed. This targets keep changing actually.
Sorry. So even if the target changes, there is the theme. The theme is about one particular friend of his and repeatedly telling
Yeah,
about.
exactly.
Yes, yes.
But
That's
he
the
keeps
thing.
telling the same things what he has seen. He does not cook up anything basically. Yeah.
Yeah, and if you stop him from doing that, what's the result? What happens?
We have stopped and he's understood that we are getting annoyed when we make angry face or annoying face, then he stops, doctor. But there is one point when he feels very frustrated. Like after maybe 5 days or so, he feels very frustrated and he throws it out like anything. Like he shouts very loudly, taking their names. Like I would feel that he wants to say that I want to say this and finish it off like that.
Does he talk to you as a give? Does he give it to you as an information, or is there some clarification sought from you about it?
Not like
You
that.
got my question?
Use as an information.
Just
Doctor,
like
like.
that. He just says names. For example, Yusuf and Sahas. Yusuf and Sahas, like this, he keeps screaming like that. Suddenly, two names he takes. And I feel maybe he's picked up.
Sometimes he comes back from the school, he says, okay, yeah, hi, Saha's father, something like.
Ah.
Means he knows it's not that, but when we go out also, he greets some people, hello, like some of his friends' name, he takes and he says, hello, Ethan's father and all. But when we say no, talk properly, then he tells. But this thing is like recurring.
And this he does like to see our reaction. If we are showing any reaction, he wants to test with the outsiders also.
How old is your child?
He's
9 years.
9 years. He'll be 9 in May.
And the way you describe, I sense that neurotypical. He has this thing as well, right? A spectrum.
Mild autistic.
Yeah.
Right? Yeah.
Yes, yes.
Yeah. So this looks like possibly a issue associated with spectrum more than an obsession as such. Because they have certain things they need to know, they need to tell or need to ask. So they have this, and like an idea which comes into their mind, they have to do it.
Yeah.
So it's like more than like that, more than anything else. It's basically insistence on sameness, the cognitive inflexibility which we talk about.
Okay.
So it's more of that rather than obsession is what I can tell you at this point in time.
So if cognition increases, then this might rule out, is it, doctor? Anything like that?
No, see, the nature of autism spectrum is such that the inflexibility is usually present, and I have seen people who are 50, 60 had diagnosis early in their childhood, very clear diagnosis in their childhood. Their inflexibility will always be there. Like, for example, one person, while we had employed him at Nimans, we had given him accommodation, as in he was working in one of our records room. He had this exactly the way you described, no? So asking the same thing, where are you from? Which place are you from? And he would tell, I am from this. So they have this the sameness, that they have this fixity on certain patterns. So the point is, it will not decrease, but with certain measures like I'm so sorry. With certain measures like making them distract without understanding the child fully, it's a bit difficult. But there are certain things which we can make the child to do, and then the child will get distracted. Plus, answering too many times might actually kind of reinforce the behavior. That's one thing. And but with age, this does decrease. But like it doesn't mean that with increase in cognition, this will change. I wouldn't tell that. If that was the case, then most of the autism spectrum cases would have gone off because it's a spectrum is a lifetime diagnosis, like we all know. So, was I able to answer your question satisfactorily, Rohini?
Yeah, Dr. V, go
Actually, what I wanted to, one more thing I wanted to share was he was already under behavior therapy, and they are asking us to ignore whatever he says. Asking us to totally ignore always. But when we follow that, it is again he's seeing doing it with outsiders. There we are not able to ignore these things happening. So we don't know if ignoring is the only way to.
No, ignoring need not be the only way. Understanding where it comes from.
The root cause.
Maybe see, there is an element of anxiety. Many kids with autism spectrum diagnosis, a lot of inherent anxiety. Anxiety is very common in autism spectrum disorder. It's very common. Around 90% kids many times have a lifetime prevalence of anxiety. There's an element of anxiety which I can sense in this child. I'm so sorry. Continue.
Doctor, we have collected some questions and sent it to you already. So, do you want to address them? I have the document open, or do you want to take up questions from the participants?
Let us make it interactive also. We'll come to that.
Okay.
We'll make it interactive.
There's a question about how to find autism OCD in non-speaking individuals. It's there in the chat. It's also repeated in the questions.
Exactly. That's the reason I said some are repeated. And anyways, I'll be covering everything. Whether I might not talk to the I might not answer that question directly, but I'll be in my discussion will generate solutions for that. So see.
So do you wish to address that, the difference between OCD and OCPD in non-speaking individuals?
See, OCPD, it's a personality disorder, meaning it's their nature. That there are, like you might know some people, right? They are very specific when you give especially teachers sometimes are very particular. I'm not telling that every teacher will have OCPD, but it's like say there is a punctuation missing, there's a this missing, they will become particular and they'll get angry. So much so that, and it's also about themselves. When they do something, they have to finish everything to the manner which they expect. That is a personality, and that usually starts after personality starts by 16, 17, and 18. And many kids with developmental delays, we cannot properly assess personalities because developmental, especially with conditions like autism spectrum, they tend to have an overlap. The autism spectrum many times overshadows the personality. So giving a diagnosis is very difficult in that situation. I would, in fact, rather not want to give a diagnosis unless I assess that person and how verbal, how much that person is able to function in the society and all those things. And OCD, one thing you need to remember, compulsion is the key. If you want to ask me what is one key, the compulsion and the associated distress if you stop a person from doing compulsion. Like say a person has a thought about hands getting dirty. The thought is so overpowering that that person wants to go and wash hands repeatedly. And if you stop that person, like lock all the bathrooms, for example, then that person will get very distressed and will start getting angry, start throwing tantrums, or start becoming very restless, agitated. So compulsion and the stopping from doing that compulsion, what happens is usually the crux of OCD, I would say. Because there can be compulsions without obsessions, especially in non-verbal people. But compulsions are usually a must in terms of OCD.
Another general question which was asked was a lot of self-harming behavior. You addressed that as well in the slides. So if there may not be a compulsion component attached to it, but does it count as anxiety or should it be diagnosed for OCD?
It is neither anxiety. See, autism per se has these symptoms, which is neither anxiety nor OCD. Okay, a child with autism spectrum can involve in repeated hand flapping. It's more of, in fact, a gratifying behavior. See, even we tend to do sometimes, right? We tend to tap our feet when we are sitting in a, or we tend to do certain, fiddle with certain things. So it's
So
like
this
that.
is more of hitting self, hitting the head on the wall, or pinching, and that leading to bleeding and all that injuries.
That is self-injurious behavior, again, a part of autism spectrum many times, most of the times. Especially the one thing we need to know, if the IQ is on the lesser side, the lesser the IQ, these risks are higher. The lesser the verbal ability, these risks are higher. And so these are the two most important factors, I would say. And I would still want to diagnose it as a part of autism spectrum rather than diagnosing it as anything else, especially if it's a younger child and with severe autism spectrum symptoms.
We have a couple of parents who raised their hands. There's
Yeah.
Bindu, Smita. Bindu, do you want to? Sorry, Bindu, do you want to ask your question?
Yeah, sure. Hi, Bindu. Hi, Doctor. So nice to hear you answering a lot of our questions, which we did not have an answer to. For example, the prevalence of tic in children with OCD. Uh, so I want to talk about my son. Till 12 years of age, we did not have any major issues with him. He used to sing, he used to go to a regular school and all that. But when he turned 12, we kind of noticed him washing his hands frequently, not interested in a lot of things, did not want to sing, did not want to play the piano, a lot of disinterest. So we have been going to many doctors. Some of them pointed to being on the spectrum. Some others identified it as OCD. And to tell you the truth, right now he's 16, but I don't know if we have really got help for what he should be doing or what he should be performing at his age. So yeah, doctor, how we should be able to help him out.
What is he studying now?
He is doing his 11th, doctor. He is doing NIOS in Dean's.
Mm.
But he's not performing as per his potential, because we know him as a child who was really capable of a lot of things. But right now, it's all underperformance, and he is doing things just for our sake. It's not.
So the performance dipped recently, is it?
Not recently. For the past 4 years, I should say that there is no interest. He's not interested. He's doing it for us. And like you mentioned about writing and all that, he does not like to write. It's just out of compulsion he will write. And this is a child who had a very beautiful handwriting. And right now it's more for the sake of us. And if we compel, it can even turn into aggression. So we are treading on a very dangerous zone, actually.
You said people have told you about the possibility of a spectrum. Tell me more about that.
Spectrum, because when he was 5 years old, in fact he was a late writer. He wrote very late. When he joined his school is when he started writing. Before that, we found it very difficult. So a few of his preschool teachers had asked us to get his test done, and we had been to Dr. Mahadevaya, and he had mentioned that could be on the spectrum. I'm talking about doctor from SSK, Mahadevaya. He had mentioned that could be on the spectrum, and a couple of things like imitating teachers and getting into trouble, all that was there. But then it was all in a very funny way. He never actually, we never thought it was more than anything being naughty. So it went on till 12 years. He was part of the church choir. He used to sing very well. He used to do things which any other child would do. But 12 years is when we kind of realize that a lot of actions, like, for example, washing the hands and not coming out of that place of washing his hands. And when you try and pull him out, he'll say, no, 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 I need to wash a little more. So he's verbal. So he'll tell you. But then he's not able to tell us what these intrusive thoughts are. We would be more than happy if we can get to understand what those thoughts are so that we can arrest it and we can help him out. I don't know. Maybe we can talk about it and help him.
Have
But
you ever
then,
gotten evaluated by any
yes,
psychologist or a
yeah,
psychiatrist?
yeah, yeah. We have done all that, doctor. But then I don't know if we are on the right track. Right now, he's going to St. John's. We're getting it done, and he's on a couple of medicines also. He's on venlafaxine, then SNRI. He's on an SNRI. Then he's also on chloracifam when he does not get sleep.
What
Yeah.
was the diagnosis at St. John's?
St. John's also it's OCD. There it is OCD with comorbidities. His autism is also interfering, but it is mostly OCD. What they said is we should have ideally identified OCD and started treating it early. But then they said it's not too late because he's only 16. We can help is what they are saying.
Did he have a speech delay in early childhood?
No, doctor, nothing that was alarming. I mean, he used to talk, but right now sometimes we have noticed that there's echolalia. He keeps on repeating, and I wonder how did that happen all of a sudden?
Echolalia, that is where, see, many times now the terms are a bit misleading. Just
Hmm.
because somebody is talking to himself or herself doesn't mean it's echolalia. Even,
Okay.
even we mumble under the breath sometimes, no? Even we do that, right?
Yeah. Yeah.
Maybe there is some thought which is in his mind, and then because of
Okay.
that, he's responding to that. We don't know. But echolalia is not like that. Echolalia is a completely different phenomenon where they one person with echolalia, like usually a kid, tends to repeat the same thing when what they hear, the immediate or delayed. And
Hmm. Hmm.
echolalia cannot start at this age. And the way your son has been functioning
Hmm.
doesn't look like. I mean, there is a plus minus chance that there is autism spectrum. Assuming that he does not have autism spectrum, then
Hmm.
echolalia does not come into picture at all. And assuming that
Okay.
possibly has a few symptoms of autism spectrum, maybe,
Okay.
which I'm not sure. Okay,
Okay.
the rider I'm telling very clearly, which I'm not sure.
Okay.
But the way he's functioning definitely rules out echolalia. Echolalia is also in kids who don't who have a much more severe symptom of autism.
Hmm.
Um,
Hmm.
and
Okay.
that too at this age, echolalia will the way you say it, it has only emerged now, right? It's not persisted.
Yeah. Yeah, he has got certain tics also. I mean, suddenly his hand will start shaking. And all these are recent. It's not something that we
Many times,
saw earlier.
no. See, OCD is a very tricky illness, I'll tell you. In fact, to be honest, no, in my 15 years of experience as a psychiatrist, the disease which I find it very intriguing is OCD. Even schizophrenia is very simple, actually. It's
Yeah.
glorified.
Yeah.
It's difficult,
Hmm.
but it's easy to understand schizophrenia, even other things. But OCD is the toughest disease to understand and very difficult. So possibly I would still want to give a benefit of doubt and keep everything under OCD only. Because I
Hmm.
have seen the symptoms in kids with OCD. I've seen this happen.
Okay.
Yeah.
Doctor, we have
Anjuji,
a couple of questions in the
just
chat.
1 minute. It's 11, so in another 15 minutes, can we wind up? 15 minutes or so? Hmm?
Yes, sir, sure, sure. So we have a couple of questions in the chat also. It says, talks about verbal stimming and flapping with hands. It's increasing, it is interfering with the daily life. Is this OCD?
This one, right? Hmm. See, stimming is definitely not a part of OCD. Stimming, I'm sorry. Stimming is definitely not OCD. If you feel it's when you stimming is more of a sensory seeking phenomenon where like you're doing this and you enjoy the joints and the body part being vibrated. You get a sense of joy. In OCD, it's not that. A sense of distress to be relieved. That is, it's completely different. Here you're seeking something actively. Here you're avoiding some harm by doing something. So that is one thing. So stimming per se is not obsession or a compulsion. It's very much a part of autism spectrum.
And can OCD be masked? Root asks, can it be specific to a particular place? Child has OCD in some place, and when he goes to some other place, it's not exhibited.
That's a wonderful question. I would really appreciate that person who has asked it. But OCD can manifest in certain situations. The illness, you have fever, it increases during evening or at night, but morning fever is less. Doesn't mean that fever comes only in the night and then goes off in the morning. Not like that. Maybe it's sub threshold, it becomes a bit less, that it is not noticed. One thing. Second thing, it's also um, maybe there are certain environmental triggers, like say, for example, a person with cleanliness compulsion and obsessions, hand washing. Take him to a garbage can. Take him near a garbage can. Obviously, that person will become very stressed. He will not want to even come near, and he will just by the thought of. Many times I've seen even the thought of a garbage can, even the thought of a dirty place, they go and wash their hands. So, to answer your question, many times it is situational, but if once OCD is there, it cannot, please don't be under the impression that it is there in one situation and it cannot be in the other situation. It's not like that. Maybe the illness is mild and hence it's manifesting in certain context. We call it context. OCD is known to have, like, see, I know certain girls with OCD, especially during periods, they spend so much time in the washroom. Natural, right? Because there the cleanliness question becomes a bit more. So, like that. I hope I answered the question.
Thank you, doctor. Yeah,
There are
that
few
answers.
people who raised their hands. Smita Hiremat has been waiting. Smita, would you like to ask your question?
Yes, ma'am. So I have a son who is 14 years old. Um, though he is not diagnosed with autism, because last time in 2020 when we did the assessment, they said he doesn't have ADHD or autism or anything, but still everyone says that he is on the spectrum. He has mild symptoms like, social skills are very low, and there are certain things, but my question is like, he is capable of doing so many things independently. So now whenever I'm trying since last 3 4 years to make him do the things he can do independently, he becomes like, too much attached to me, always being around me. And during COVID also, I was hospitalized suddenly, and it was very critical condition. I was in very critical condition. So many things has affected him, obviously. But before that also, I have observed this. So my question is, can it be a like separation anxiety or something? Because now he's taking medicine for anxiety, because last year I found too much of obsessive behaviors in him, so I went to St. John, so started the medication for OCD. So OCD, the main symptoms what we went for has gone down, but the other things, were visible after, moving the certain curtains away. So when I mentioned, the
Wonderful
doctor said that
question.
he has anxiety. Yeah. So for anxiety, they are continuing the same medication. But now I'm seeing more of this thing to do with me, like, being with me, asking, are you happy, mommy? Are you, happy with my behavior? So is this a separation anxiety or something?
See, in fact, the halfway when you were narrating the things, that thing, separation anxiety, popped in my mind actually.
Yes.
Many kids, just to ask few more questions, can I ask you, like, was he since early childhood like, a bit clingy to you early in the childhood, would not separate from you, and
When we go out and all, he goes with our relatives, friends, spend time with them. Sometimes he wants to sleep with them. He does all of that. But
early childhood? I'm referring to early childhood.
yeah, early childhood also he was trying to make friends, and all social thing is very low since early childhood.
I,
Um,
just to sorry to interrupt. Just I
yeah.
got the question. So see, when you are asking about, I would not feel that. See, it's an injustice on several kids. Everybody is randomly labeled as autism spectrum. I don't believe that because I mean, with all due respect to whoever does that, but see, just because a child has social skill deficit doesn't mean that it is autism.
Yeah.
So autism spectrum is a spectrum. It has to have certain categories and criteria. Nowadays, what has happened is the awareness has become so much that sometimes parents themselves read up and then they feel, okay, my son has this. But it's not like that. Social skills are a repertoire, are a big spectrum, big umbrella. And
Yeah.
under that, there are certain conditions. Even ADHD can have social skill deficit. Even many things can have social skill deficit. Autism is a one condition which is very crystallized in terms of having other things also along with that.
Yeah.
So usually sometimes they tend to lose the. So this kid is more of an anxiety plus social skill deficit and some amount of reassurance seeking. Maybe there is separation anxiety the way you describe. Plus there is something else also, let's say generalized anxiety or other things. That will be evident once we do a detailed assessment. Once he undergoes a detailed assessment or anywhere. And you said he's also on medications, if I'm not wrong.
Yes, doctor. For anxiety, he's taking
And
para something. I don't remember the name.
which one? Sorry.
I don't remember the name. Uh, so he's taking 40 mg of I don't know, remember
Prozac,
the name.
Fludac.
No, doctor. You mentioned in your content also. I don't remember the name.
Sertraline. Anyways, it's okay.
So
Hmm. So see,
Prodap only, doctor. Prodap only.
I got it.
Yeah.
So see, definitely there is anxiety, and sometimes a rationalization of medication or addition of therapy to these things is a very important. Therapy is many times underplayed because or not utilized because of the availability, because of the lack of availability of the trained psychologists also many times. But therapy
Yeah.
is one thing which helps a lot, and not behavior therapy. I'm referring to. I'm referring to CBT in a kid who is like this, who is well, who has so much of good abilities and has but certain
Yeah.
difficulties.
Yeah, because see, I am also a psychologist and counselor, and I am working as a special educator also now. So as I see my kid, obviously as a mother, if I see my kid with all my knowledge, what I see is the anxiety part and the social part, mainly, making him to behave in a certain way, where the people are, categorizing him as a child on a spectrum. If we remove that, he is okay. I mean, as a mother, I'm saying, maybe, as a mother, the emotions will be there. So I don't know, doctor, if the anxiety part is removed, so many things will come on track, I feel.
Chief, has anyone worked with him on social skills?
No, doctor, not it.
See, the way you say no, see, when somebody has poor skills in social situation, obviously they will not want to go and interact with someone, right? And because they don't interact, they'll not learn the skill. So it's a vicious cycle. And because of that, they become more anxious. And so it kind of multiplies or even becomes geometrically progressive, harmonically progressive.
He goes everywhere and talks to everyone, but after certainly, some questions from his side and their side, he doesn't know how to go about further. So
So that
there
is,
his conversation ends.
did he have speech delay in early childhood?
Yes, doctor. Actually, what happened? He started speaking at a normal this thing only, but we went to US, and when he was 1.5 years, they suddenly said that for some health reason he went there, and they wrongly diagnosed as uh, I don't remember. So heartbeat elevated and all, they said, and they admitted him in cardiac ICU. Hypertension, sorry, hypertension, they said. And in the X-ray, it came like something sticky is there. And I said, I, fed him banana in the morning. They were not ready to accept it. And they said it's a hypertension. 6 months went on, and he was on oxygen also for almost 2 months, and then 6 months during night oxygen. and he did not need that, because he was playing around, walking around nicely, and after the discharge from the hospital, so many things happen. And after that, so we saw that the child who was speaking in a sentence of 3 to 4 sentences, 3 to 4 words, suddenly became like 1 or 2 words. There was a regression. So
I got
that
it.
has happened.
We don't call it regression in a very technical sense. Regression is many
Huh.
times used loosely. It's
Yeah.
basically a loss of acquired milestone, I would say.
Huh.
It's very well known that early in childhood, 1.5, 2 years old, when there is social isolation for whatever
Mhm.
reason, and when there is inadequate stimulation. Obviously, we're running around for the medical management of the
Yeah,
child.
yeah.
So, and especially in countries like USA, the support system is very limited. So, obviously, these factors would have added on. Anyways,
6 months he was totally at home, doctor, because we were unable to take him out because it was winter season, and he was on oxygen and all those things.
exactly.
So yeah,
So,
isolation complete.
the long and short of it is, see, there are social skill deficit. That doesn't mean it's autism. Okay, but
Yes,
this is my
yes.
opinion, and this is what I believe in strongly.
Huh.
And working on social skills is the most important thing in this situation. So you can find a place where you are comfortable and then work on that. That is most important.
Okay, doctor. Thank you so much.
Thank you.
Yes,
We'll go to the next question. There are two. I see two more hands raised. Barnali and
Please ask your question, Bernal. Bernali, are you there?
Hello, Vindu. Can you hear me?
Yes.
Hello. Yeah. Good morning, doctor.
good morning.
Doctor, my son is 18. He's largely nonverbal.
Mm-hmm.
Whole thing started 5 years back when, since he's largely nonverbal, he started calling me mama. Like in Bengali, we call mother is ma. So I was very happy. So naturally, he started calling me, and whenever he comes to me, he will say. Then it became a pattern, like ma, that kind of sound. And it started happening. And initially, I was not aware about I didn't have this concept of OCD. This is a new term to me. I was not aware. I was very happy. My son is calling me. And it started 5 years back. So and slowly, now it's become a pattern.
How old is he now? How
Now
old?
he's going to be 18. This February, he's going to be 18.
18.
18. And now it's become a pattern. Whenever he comes to me, or even I'm not looking at him, I try to ignore, since it's become a habit. This is one thing. Like he will make that sound, and like lot of times in a day. And I ask him, whenever I ask him if he wants to say something, he will say no. Just for the sake of calling me, he's calling me. This is number one. Secondly, doctor, since now I have become aware of the fact that this OCD happens, I started reading about the term. So, and there are a lot of things, like he can't see anything tied up. Like any rubber band, if there is any sweet box or anything anything tied with a rubber band, we'll open up all these. Then powder, if the talcum powder, he will open up the thing. Toothpaste, he will open up all those things. All these things started happening. And one more thing, doctor, he takes medicine for thyroid. He's suffering from hypothyroidism. So he takes medicine for thyroid. He's become very lazy. Like lot of things happen him all of a sudden. Last 2 years, things have aggravated. He takes medicine for anxiety. He takes medicine for concentration. And medicine started, he started taking, that's also 5 years back, 5 to 6 years back. So my question is, doctor, how should I react about it? Should I ignore all these things? And since this is not, and he's become very slow. Initially, I thought he's lazy, but after the medication started, when we consulted the doctor, so he said this is because of, and it showed that he is suffering from hypothyroidism. The blood test showed. So he started taking medicine. My question is, doctor, is this related? OCD and hypothyroidism, somehow it is related. It comes, is it linked somewhere?
See,
And how should I, what is your suggestion for me? How should I go about it?
There's no absolute causation, meaning kids with OCD or people with OCD will have hypothyroidism, or people with hypothyroidism are known to have. Hypothyroidism is a very common medical condition, and so is OCD. So more often than not, they might co-occur or coexist rather than, or they are comorbidities rather than being correlated. They are not correlated in this
Okay.
case,
Okay.
usually. Okay,
Thank you.
maybe even depression is a lot more correlated to hypothyroidism, that to very severe hypothyroidism, not regular, not a mild subclinical one.
Okay.
One thing. Second thing, when you stop him from doing that, telling ma, when you ignore, what
Mhm.
does he do and how does he react?
He waits for some time, he continues do that, then he goes away.
So he doesn't bother after you stop, after you ignore.
Um, no, he bothers. His face is different. He looks different. But still, if I don't give any eye contact, he goes away after some time. But
And
but doctor, if that happens with that rubber band thing, that if somebody is tying up the thing in front of him, then the aggression comes. He can't tolerate that.
okay, then what happens? What does he do?
He will open it.
Hmm.
Somehow he will find out that thing, what is tied up, he will open it, he will find it out, and he will open it, whatever said and done.
See, what we need to remember is kids on the autism spectrum disorder, they have something called peculiar interests.
Mhm.
Like he's fixated on rubber bands and something tied with a rubber band. He has a peculiar interest. So much so that he will stop everything else and do it. And he will do it so much so that if you stop him, he will get distressed. That doesn't mean OCD. At least the way I am understanding your son now. And see, there doesn't seem to be any compulsive behavior where he is driven to do something, and so much so that he keeps on doing it repeatedly and so many times and those kind of things. Doesn't look like a OCD, but there can be some amount of anxiety associated with, like, that is where he's trying to, because he's not verbal.
Yes,
Maybe a signal of reassurance seeking in certain anxiety situations.
okay,
So need
but
to
it
understand.
sounds, doctor, it happens at times, maybe 30 times a day,
Mm-hmm.
this calling me,
Mm-hmm.
or it could be more than that. Like it becomes so annoying at times. So that's why,
That is reassurance seeking, classic reassurance seeking, where they'll
okay.
come and tell something repeatedly. Like, say, they have something to say. Say you are anxious and you have to tell something.
Mhm.
You will not even bother. I'm so sorry. You will not even bother whether the person in front of you is interested in it or not, right? There is so much
Mhm.
of pressure from inside to tell that, because you want to tell it and you have to seek reassurance. Okay, nothing will happen. So, but he is not able to seek reassurance in a classic manner. Possibly, he might be telling that because there is some anxiety-provoking thought or something in his mind, and then comes and does that to ma. Because obviously, you are the primary caregiver and you are
Yes,
majorly related, as in you are the one who is through the day with him. Is
yes,
what I
yes,
understand, right? So,
yes, yes.
but it doesn't look like an OCD as such.
How should I react, doctor? What should be my behavior?
See, it needs a lot of contextual understanding. It needs a lot of dissection of several things, and difficult to give a ready-made answer. But reassurance seeking, despite medication going on, not
Mhm.
subsiding, will need a revision from your psychiatrist. Speak to them, and maybe a therapy session with the child or with you, like how to understand further, will help.
Oh,
Um, Especially because there's not a verbal child, it's very difficult to understand the non-verbal child's mindset without understanding the contexts. I
right.
know I'm not able to fully answer your question. I wish I could.
No,
Um,
no. Thank you
and
so much,
understanding
doctor.
the
At least,
child's mind is very important, and that can happen only when we understand the child's context in a much more detailed manner.
doctor, like just a last question. Like I should every time he calls me, Like I should answer 50% of the time and I shouldn't answer 50% of the time. It should be like that.
Yeah, answering once or twice understandable, but if the expectation is to answer every time, respond every time, and then
Yes,
leave
that's the
everything, then it's not a appropriate one. So it's not about the percentage; it's about what is compelling that kid to tell ma repeatedly. That is more important.
okay. Okay, that actually I need to find out. I don't know. I need to find it out. So that's why I need guidance. Okay, thank you so much, doctor. Thank you so much.
Doctor, there are a couple of questions in the chat also which associate.
11:22. By 11:30 we'll wind up. I have to.
Yes, sure. Yes.
11:30,
Yes. So there are some questions on how if PANDAS, PANS, and viral fevers, eye blinking, are they associated with OCD in any form?
See, pandas was one concept which had come a couple of decades ago, and then when it came, it was romanticized a lot. I'm using the word romanticized because it had a lot of attention and all those things. Till now, I have not seen a single case of pandas. And forget me, I'm a much younger psychiatrist. My professor at NIMANS, who is one of the most leading physicians of leading psychiatrists and OCD expert, Dr. YC Janardhan Reddy, he himself says that he has not seen a single case of pandas so far. See, theoretically, there can be something which trigger, like say infections or those things, but sometimes those things get unmasked during infection. But don't chase pandas. In the summary, I would tell, don't get too much fixated on that. OCD is OCD, whether it starts because of anything or not. Maybe a basic investigation with one or two blood tests. That's it. Rule it out, and that's it done. Don't get too much obsessed with any of those labels. One time it had come, and it was there was a huge interest in that kind of a condition. Now eventually it has died down.
Priya has a question. Priya has her hand raised. Priya,
Good morning, doctor. Thank you for this very informative session that you did. It was really, it opened our eyes. We recently got a diagnosis of OCD for our twin girls. They are on the spectrum.
How old are they?
16. 16. So through the last 2 years, we've been noticing a lot of behaviors. And there is also this undercurrent of anxiety, which is always there. So, when there is a lot of hand washing and all the symptoms that you said, we see all that in action at home. So, what the doctor advised us was that, this is OCD, under that there is anxiety, and below that is your PDD-NOS or whatever diagnosis you have. So, we have to work on it on the reverse order, like work on the OCD, then the anxiety, and then, the therapies with respect to autism and all is anyway going on. So now we've been at
How much verbal are they?
They are very verbal. They can share their thoughts and all. And in fact, they, tell us that, we have all these thoughts going on in our head. Both of them are manifesting symptoms in different ways. For one, it is always repeated hand washing. For the other, it is repeated watching of certain rhymes, certain rituals, which seem like an autistic ritual, but they are not actually autistic. It is more OCD is what we were told. Now, we have been advised fluoxetine for both of them. And what the doctor told us was, there's no telling whether this medicine will work. Unless you try only, you will know. And also, there could be a potential side effect in terms of increased irritability, some gastric issues, so many side effects could be there. So then we are really at a quandary as to what to do, because if it's like increasing the irritation and hence increase.
How long has it been? I got it. See, I'll come to that. This is one of the commonest doubts which parents will have. So don't worry. How long are they on fluoxetine or not started yet?
We have just been recommended that, doctor.
Not given yet.
Yeah, not given yet.
Fluoxetine is one of the best medication. We call it gold standard medication in OCD. Okay. There is a theoretical chance of increase in irritability. You see, it's a duty of the doctor to narrate and tell and describe what might happen in terms of common side effects. We call it behavioral activation. Okay. So that doesn't mean that they will become irritable. Okay. That chance, maybe I would say See, in 100, I see 1 or 2 kids having that symptom, that at the most, that activation. Okay. And all said and done, the risks are far, far less when compared to the benefit of the medication. Okay.
Okay.
If not fluoxetine, then there is something, there are other medications also. The reason they say that it might not work is we have to try, right? The proof of the pudding is in the eating.
Mm.
Doctor, whoever has told that has told it in very good intention. Sometimes parents know when they are anxious, they tend to kind of get worried when these kind of things like irritability it might worsen. So many times that is where the psychoeducation session. Sometimes I spend one entire hour psychoeducating about the medication, and I don't start that until the parents, all the stakeholders are on my side. Sometimes I take the grandparents also on my side, like 5, 6 members before I start the medication, because many times there are a lot of doubts, and many times what happens, these activation is a part of an illness itself. uh, when the illness starts resolving initially, sometimes there might be some symptoms which might become more obvious.
Okay.
So all said and done, if they are wanting to start fluoxetine for the OCD, then it's always good to go ahead with that.
Okay. The other question is, there is a lot of talk about CBD, cannabis, helping with such cases. What is your take on it, doctor?
They're anecdotal.
Okay. There's no proven.
Like I have tried in this child, it might work. It has worked. See, fluoxetine, they would have tried in thousands of kids, lakhs of kids, millions of kids, and then they know it works almost like in 60% of the cases. But here, this is like doctors' experience, nothing else. There are no trials, there are no landmark trials, there are no countrywide trials for for this. So CBD is a new thing, and that is being purported as a remedy for everything. We need to take it with a pinch of salt, rather a ton of salt, I would say.
Okay. Okay.
Nothing can like become a panacea for one thing. And see, I am a doctor and I'm open to evidence. But
You were also mentioning about Ayurvedic treatments, right, doctor?
Yeah.
So, if we visit you, could you help us with that as well as to what would
of
help?
course, see, Dr. Kavyashree, she was a Ayurveda psychiatrist in Nimans, and now she is with us. So you're free to visit her and get her opinion. And she is very true to her trade. She doesn't use any other medication. She doesn't talk about anything else. And she has worked shoulder to shoulder with psychiatrists, like the modern medicine psychiatrists. So that way, it gives her a unique insight into illnesses. So you're most free to consult her.
So, what is your take, doctor? Ayurveda, does it work better than?
See, Ayurveda, everything has its own limitations, I would say. Everything based on the individual, we have to tailor the medication. And see, and this is what I believe in. My belief has been we should allow the client to choose what they are comfortable with. Like, see, if somebody has a fracture, obviously, and a very bad fracture, they have to be operated. You cannot leave that. But this is a condition where if a family, like a skin condition or a mental health condition or a joint condition, they have a right to choose what they want. So I will never object to this or that or recommend any particular thing.
And these are more chronic in nature, no, doctor. So, it's like if the treatment is prolonged, there is a certain worry in the mind about giving medication for so long, right? So
That I would want to kind of deny with all humility, because it depends on the there are people who have been, I've seen people who are on medications for 20 years, 30 years, half their life, more than half their life, and they're doing well. And they tell, without this medication, I just can't do, because the illness has been so severe. And it's not the medication which is making them addicted. It's basically the illness which is resistant to go. See, usually what you need to know, in any illness, roughly, one set of people will improve very fast with medication. And maybe those people would have improved without medication also, in most of the illnesses. OCD is not one of those, but still. And one set will need long-term medication, and then they improve then they continue improve without medication. One set will, despite medication, they worsen, and sometimes several medications we have to give. So it's the natural history of the illness rather than the medication which makes the person dependent on medications. Dependent, I'm using the term loosely, but basically when I say dependent, they cannot do without medication is what I am trying to tell.
Okay. And one related question is the therapy approaches. What sort of a counselor or what kind of a specialist should we look at, and what should we look for?
A qualified clinical psychologist for CBT is very important, especially OCD is very difficult to treat in terms of therapy, and it needs a lot of expertise in handling. It's not like a regular CBT for other things. And with all due respect, sometimes the word CBT is also being abused now. For everything, they start telling CBT, CBT. CBT has a specific pattern to it, right?
Would you have any, because there is autism, we need somebody who is aware of autism plus adolescence plus OCD. So finding that kind of a combination, I guess it's quite hard to get somebody like that, right, doctor? So do you have any suggestions on whom we can talk to?
Dr. Purnima I'm not trying to market for my center or anything. Dr. Purnima and me were very good colleagues at NIMANS. We know each other for the last 13, 15 years. And now we work together at my center, and she's a PhD in OCD and childhood OCD. And so she's a child psychologist, so she's obviously aware about autism and other things. In fact, she helped me with half the material also because of my time constraints. I couldn't. So Dr. Purnima is one very good person, I would feel, in this case, where she will help you in terms of understanding the OCD plus other things also.
In our case, the kids are wanting to get help to come out of this. They do understand how disruptive it is in their lives, and how much time is getting wasted. There's a lot of wastage of productive time, which they are aware of themselves. So they are willing to take help. So we want the right professionals to get on board for us.
Definitely. See, it's very important to have a skill, especially in these situations where we are dealing with comorbidities. So in terms of comorbidities, like a possibility of a PDD, possibility of a OCD, and possibility of something else. So it needs a lot more expertise to tease everything out. So a qualified clinical psychologist and if possible, a PhD in psychology, child psychology. So that is what I would recommend.
Okay. Okay.
Nimans,
So
Nimans
in
is
your
one, Nimans, St. John's, and there are other few centers, but Nimans and St. John's majorly for Bangalore people, and Dr. Purnima at my center also.
Okay. So if we come to you, I guess you have one under the same roof, right? I mean,
Yeah. See, I don't want to make it as a thing which I go gaga about.
I know, I understand, doctor.
Please feel free to visit us, and we'll see how best we can help you. Okay?
Sure.
Yeah.
Sure, doctor. Thank you so much.
Doctor, thank you so much for taking time today. The best way to reach you out would be at Nimans or your
There's
center.
one more Piyush hand raised up. So maybe
Yes, doctor.
I'd like to take that question, sir, because you said 11:30, so
it's fine. I mean, I understand, but I'm also down with a cold, so.
So, doctor, my son is. Can I ask a question?
Yeah, please.
yes.
Yeah. So my son is 12-year-old, diagnosed with mild autism spectrum, and he's non-verbal. He has that repetitive behavior in terms of spinning objects, and then he transformed from that to exhaust fans. So he's now very obsessed with exhaust fans, and whenever he sees that, he will be kind of out of control. So we don't know whether we should stop him or we should encourage him. We had visited some of the doctors who said, probably you should not obstruct him, let him do that, or you should give him some time so that he will calm down. But then whenever he goes in a public place, it is very difficult to control because he will move around and he will start looking for exhaust fan everywhere. Whether we go to restaurant, whether we go to somebody else's home, he will straight away go to bathroom or maybe kitchen where there are exhaust fans, and he will start rotating with hands. So my question was more about how do we handle this? Would it be therapy, or is there any medication which can help on this particular situation?
Coming to medication for peculiar interest, it's very difficult. There are no medications for we call it peculiar interests.
Okay.
And there is no medication for that. keeping them involved, keeping them distracted, like say involved in other interactive activities. How much does he do?
So we try to do that. We are trying to do with cycling, or maybe doing some building the blocks, playing with different toys like tablets and all. He likes to enjoy watching videos. So we sometimes run those videos on TV. He'll get distracted. But the point is, he will be uh, like so much excited when he sees those fans, and then he will forget everything else.
Yeah. See, rightfully so, you did not stop him, but maybe like say gradually make him like say 10 minutes, 20 minutes, maximum 30 minutes in a day, he will involve in that. Where
Okay.
maybe you can give him a small toy fan where he will play with that with himself for some time. This strategy has helped with several kids, but it's not a universal one, not a blanket one. Let me tell you that. But see, he has a peculiar interest. So maybe like trying to draw an image of a fan, trying to build up on something, making him study about windmills. So those kind of things, maybe trying to build on that peculiar interest is also one important thing. That should not be taken as a drawback or a disadvantage for him. Try to channelize. I know of a kid which used to have like has a huge liking for aeroplanes. So
Right.
now he has become so much adept at aeroplanes that none of us know anything about the aeroplane.
Okay.
Compared to him, he
Right.
is just 10 years old or 12 years or 10, 12 years old, and he can talk about aeroplanes for. It started with a peculiar interest.
Okay. Okay.
So you can see how you can mold into more adaptive ones and try to bring it into the mainstream. How
Okay.
old is he said?
12 years old.
So you can start making him, exposing him to other things where there is a fan, and show him how a fan works, and then understand how to utilize that. Gradually, that kind of flexibility will come.
Okay.
Also, his liking for the fan may not go. Rather than making it a war between you and the child, try to channelize and give it a proper direction. Is what we many times have noticed to work.
Okay. But then, do you classify this as OCD, or it is peculiar behavior of autism?
Not OCD.
Not OCD, because one of the counselor we are interacting right now for speech, they were saying it could be OCD, and you might have to start treatment medication.
At the face of it, without assessment, I cannot rule out, but doesn't look like OCD.
Okay. Okay. And then, do you have any recommendation on for this? Because I'm from Pune, not from Bangalore, actually. So, do you have any recommendations in terms of therapies or anything which I can do it here or visit any?
Dr. Rishikesh Behre, Manoshanti Clinic in he was my senior at Nimhans. Meeting him, Dr. Bhushan Shukla, you are very much would be aware. These are the two people I can think of. They are my acquaintances.
So, could you please repeat, sir, please?
Dr. Rishikesh Behre,
Rishikesh Behre. Okay.
Manoshanti Clinic. I don't know the address exactly. I cannot tell it
Yeah.
off the hat. But and this one, uh, Dr. Bhushan Shukla.
Bhushan Chuk. Okay. I'll search and then I'll try to get help from them. Okay. Thank you so much, doctor. I think I really liked your session and it helped a lot of queries. Actually. Thank you so much.
Dr. Raghavendra, thank you so much for taking time and giving us extra 40 minutes, although we had planned for an hour. Thank you so much. And despite you being a little off the weather, under the weather, you answered all our questions. Thank you for that.
My pleasure. It's always a pleasure to talk to parents because they are the ones who see whatever we might tell, whatever we might. They are the ones who go through the heat. They face the heat rather. They are the ones who handle, and it's their lived experiences are very important to me. I value that a lot because nothing can match that. No matter how much we read, how many clients we may see, handling one or two kids with these difficulties itself is a huge lesson. And many parents actually, I suggest them to write a book about their experiences. It doesn't have to be a great book, but even a simple book where they circulate it amongst themselves. So is very important. So with that, I would want to thank everyone for this. Thank you.
Thank you so much, doctor.
Thank you so much.
Thank you so much, doctor.
Many thanks, doctor. Thank you, Bindu.
Thank you, Vindu.